Good day, everybody. This is Chris with The Ancient Scholar, and I hope this video finds you all doing well, given the contemporary situations and circumstances we find ourselves in as a world. So what I'd like to do today is I'd like to do a clinical update regarding the SARS-CoV-2/COVID-19 situation, and this is just an attempt to remain as current as possible on emerging trends and information that is coming out regarding this situation. This is going to focus primarily on patient assessment and prognosticating when it comes to patient management. Some of the information that I'm going to present in this particular video has also been presented quite well in a podcast/video series that you can reference on YouTube, and I strongly suggest that you go and check these people out. So this is a video series that's kind of headed by a doctor, Vincent Racaniello, who actually is fairly well known because he teaches a very popular virology class either every semester or every year. So he kind of heads this video series called TWIV, T-W-I-V, and that stands for This Week in Virology. And the particular video that I'm referencing is TWIV number 595 on YouTube, and it was published on March 29th, 2020. And in that particular video, he talks with a Dr. Daniel Griffin. Dr. Daniel Griffin is a physician who is on the front lines in New York City, I believe, actually taking care of patients with COVID-19. And so he discusses some of this data in some detail. So I'm going to recap what I found very compelling from a provider standpoint, and then I'm going to spend a little bit of time talking about the basic underlying science, because I understand that my audience, who I tend to appeal to and who my videos are really, when I develop these, I think about my audience, and these include nurses, paramedics, respiratory therapists, and other allied health providers. And I understand that the basic foundational understanding behind these concepts may be all over the place with different providers, and so I'll attempt to fill in some of those gaps where they don't necessarily do that in the TWIV number 595. They just assume that you understand some of these labs. Again, because the audience that Dr. Daniel Griffin is speaking to is going to be more of a physician or mid-level provider audience, where there are certain things that we take for granted or that we understand most people in that audience would know, would have a foundation in. So even though I'm recapping it, I do think that I am bringing some value to the conversation, in that I'm helping non-physician providers understand this perhaps a little better. Okay, well, with that preamble out of the way, let's get going. All right, so one of the important things that we talked about were features that suggest COVID-19. So these are essentially signs and symptoms in patients that suggest they in fact have COVID-19. So essentially, if somebody presents with these specific signs and symptoms, there is a higher chance that when we run a swab on them and we do a PCR in that swab, it will come up positive. And this should come as no surprise that cough, fever, and dyspnea are three of the most important features suggesting COVID-19. And I would almost, at this point, I would almost say that any patient presenting with a history of cough, fever, and dyspnea is going to have, or you should think of them as having COVID-19 until proven otherwise. That's just kind of, in my mind, the default position we take, is that these three features occurring concomitantly strongly suggest COVID-19 until proven otherwise, and that's going to be until proven by a negative PCR. Typically, that's going to be a nasopharyngeal swab at this point. Okay. So with that out of the way, let's talk about some risk stratification, and let's talk about, we have a patient, we're taking care of this patient. are there certain features in the patient's signs and symptoms and certain features in the patient's history that are going to suggest that these patients are going to be at higher or lower risk for morbidity and mortality? So at this point, we're going to focus on somebody that is COVID-19, that has COVID-19 rather, is positive for the SARS-CoV-2 infection, and they are manifesting signs and symptoms suggestive of COVID-19. So what are some prognostic features? Well, in general, approximately 25%, so about a quarter of all patients are going to present with mild signs and symptoms. And that is to say that they're going to have your typical febrile syndrome, right? A typical febrile illness. They're going to have a fever, they're going to feel kind of crappy, down, some malaise, some chills, but they're not going to have concerning red flag signs and symptoms. And the biggest red flag sign, or rather symptom, is going to be complaints of dyspnea, right? So about a quarter of all patients that have COVID-19 are going to be mild. They're going to be absolutely fine. And without dyspnea, really places these patients in a lower risk group. And then approximately 75% of patients are going to be in a higher risk category. And that doesn't necessarily mean that they're going to end up in ICU on a ventilator with ARDS. It just means that if they have these signs or symptoms, the chance that they're going to have more problems, they're going to have increased morbidity and mortality goes up, and these are patients that we would want to watch much more closely. And so these features are more associated with these higher risk patients. So complaints of a headache, abdominal signs and symptoms, abdominal pain specifically, severe fatigue, and elevated respiratory rate. Typically rates over 24 in adult patients are much more concerning. And a normal respiratory rate in an adult patient is between 12 and 20. So this is tachypnea. So this is not a situation where you want to become complacent with your patient assessment, right? You don't want to just look the patient over and go, it looks like their respiratory rate is 20, right? You actually need to assess an actual respiratory rate. You need to look at the patient when you're doing your assessment, and you need to look at the rise and fall of the chest and get an accurate respiratory rate so you have good information to make these decisions. So again, in approximately 75%, 3/4 of patients are going to have higher risk, right? Higher risk signs and symptoms. Doesn't mean that they're going to decompensate necessarily, but if they have these signs and symptoms, they are more likely to have problems associated with their COVID-19. Now, some historical risk stratification. None of this should be particularly new to anybody at this point, but in general, age over 60 is a big risk factor. They have a history of diabetes mellitus, either type 1 or type 2 diabetes, coronary artery disease, immune suppression or immunocompromised. So you want to be thinking rheumatoid arthritis, systemic lupus erythematosus, status post organ transplant, perhaps different inflammatory bowel disease patients, Crohn's, ulcerative colitis patients that are taking immune modulating or modifying medications for those disorders. Right? Anybody who has a baseline immunosuppression, history of asthma, particularly severe asthma, if they have a history of metastatic neoplastic diseases, cancers, where they are receiving medications that result in immunosuppression, and of course renal disease, right? So those are all in the patient history. Those are all factors that put those particular patients in higher risk groups. Okay, so let's talk about the typical progression of COVID-19, and this is a little different than what you would normally see. And when we normally see a viral illness, typically there is a prodrome. So there are mild signs and symptoms that begin to develop. A sore throat, you feel a little down. That's called a prodrome. And then fairly quickly, say hours to within a day or so, the prodrome gives way to the kind of the full-on viral syndrome, the chills, the high fever, the classic things that we see with the virus. And then within several days, people typically get better, right? That's classically what we see. That is not typical of COVID-19 progression. Okay, so what we often see is the first week following symptom onset. So it is going to be critical if we are a provider at the bedside, we need to nail down when the patient's signs and symptoms began. We need to figure out how many days we are into this illness. But within the first week following symptom onset, oftentimes these patients can frequently present with mild signs and symptoms. You know, some fever, some chills, they feel down, they don't feel great. And this can go on for a week. And what can happen is it can lull you into a false sense of security that, hey, this patient's been okay basically for a week. They kind of have a mild, moderate viral syndrome. And so it's very easy to underestimate these patients. Where we tend to see the problems is actually in the second week, right? So days 7 to 14 tend to be much more critical in terms of decompensation. Okay, so this is typically when respiratory deterioration occurs, right? Which is interesting because what we're seeing by day 7 to 14, so typically we will see that the immune system will begin mounting a humoral response, and that is to say that antibodies are going to be produced. Typically the first antibodies that get produced are going to be IgM antibodies. Those are kind of the really big, heavy ones that form large units of 5, and then that gives way to the more classic IgG antibodies. And so what we see by the second week is that the body is mounting an immune response, and the viral loads tend to be going down. Things are looking like, hey, you know, we're on the downslope of this infection, and we may very well be. The virus may very well be at that point being effectively cleared by the body. It's mounting a good humoral response and presumably a good cell-mediated response as well. So that's what's occurring within the cells and infected cells. But for reasons that aren't fully elucidated at this point, these patients begin deteriorating. Many of us suspect that it is probably not necessarily the viral infection per se, but there are some immunopathological sequelae that occur. That is to say that the immune system responds abnormally. And I've talked about this concept of a cytokine storm earlier in earlier videos. And so what happens is it's not the viral infection per se, but there are these different chemicals, and maybe I'll do a video talking about them, but there are these different chemicals that the cells of the immune system use to kind of modulate each other, and many of these chemicals kind of enhance the immune response in some key ways. And very important chemicals are what we call interleukins, or ILs, and you have different interleukins like IL-6, IL-1, IL-10, and some of these interleukin levels may get very high, and there are even some hypotheses and some very scant data at this point, but some tentative data that suggests that blocking the effects of some of these interleukins can attenuate the respiratory deterioration that we see in these patients during the second week of their illness. So the bottom line is that it's going to be very important to closely monitor patients in the second week, days 7 through 10, maybe 7 to 14, right, in that second week. And oftentimes these patients can do well for a week or more, and then they can rapidly deteriorate over hours to maybe a day or so. So rapid respiratory deterioration can happen. So we want to watch them very closely in this danger zone, essentially. All right, so we also have some laboratory features for risk stratification, and these are really interesting. I really, just from a basic science, a foundational science, biological, physiological science standpoint, I find this rather fascinating. The classic one, of course, is pulse oximetry, and typically if we have a room air pulse oximetry of 92% or less, that is going to be much more concerning. And then one of the new things that has been talked about, which I find really interesting and really compelling, but this makes sense given what we talked about in earlier videos, where we can see certain unusual changes in the patient's white blood count. And I've talked about that in prior videos, and we're going to kind of redux that now. So there is a value called the NLR ratio, and that stands for the neutrophil to lymphocyte ratio. And what that involves is looking at the patient's white blood count. And the white blood count comes from a lab known as a CBC. A CBC stands for a complete blood count. And oftentimes the 4 commonly referenced values on the CBC, you can draw an X, that's called a fishbone diagram, and then you can put your values in. So we've got the WBC, that's a white blood count, and then up on top you've got the hemoglobin, and then the hematocrit, and then the platelet count. Right there, the platelet count. So that's the CBC. So when we look at the white blood count, there are several types of white blood cells. They're also known as leukocytes, and these are the primary cells associated with the immune system. And so what we do, and typically the normal overall white count of all the white blood cells in your body tends to be about 5 to 10,000 cells per microliter. But in this case, we need to dig a little deeper. We can't just look at the aggregated white blood count. What we need to do is we need to look at something called the differential. And the differential looks at the individual white blood cells, and there are 5 major categories of white blood cells, and I just remember them by the saying, never let monkeys eat bananas. And these stand for neutrophils, lymphocytes, monocytes, eosinophils, and basophils. I'm going to focus primarily on the neutrophils and the lymphocytes today, because that's what we need to look at to get this ratio. And they are the most common white blood cells. So when we talk about the neutrophils, they compose about 55 to 75% of the total white blood count. Neutrophils are also known as polymorphonuclear cells, or PMNs. That's the same thing as a neutrophil. And there are different flavors of neutrophil, if you will, different types. There are what we call the segmented neutrophils. These are sometimes referred to as segs. And then we have what are called banded neutrophils, and these are sometimes referred to as bands, and these are mature and immature neutrophils. And we know that when the immature neutrophils get elevated, this is sometimes referred to as a left shift, and that tends to suggest an acute bacterial infection. That's just kind of an aside to what we're talking about today. But what we want to focus on today is the absolute count. Right? So we're not looking at the percentage, we're not looking at the segs and the bands per se. We're going to look at the absolute count. How many neutrophils do I have circulating in my blood? And the normal absolute neutrophil count, this is also referred to as the ANC, as mentioned above, is 1.5 to 8,000 cells per microliter of blood. So that's the ANC, the absolute neutrophil count. And then the lymphocytes, The lymphocytes compose about 20 to 40% of the total white blood count. It's a little less than the neutrophils. And there are two flavors of lymphocytes as well, or two general types or categories. You got what are called your T lymphocytes, and your T lymphocytes form what's known as the cell-mediated response. Right, so this is the intracellular response to viral infections and cancers and things like that. And the T lymphocytes actually mature in response to hormones that come from the thymus gland near the heart, and that's actually why they're called T lymphocytes. And then you have different kinds of T lymphocytes. You've got helper Ts, killer Ts, natural killer, etc. You also have what are called B lymphocytes, and B lymphocytes are very important when it comes to the humoral response. And humoral just comes from an old Greek word called humor, and humors refers to body fluids, and specifically this is going to occur within the blood. So the T cells are within individual cells, infected cells in the case of a virus, whereas the B lymphocytes are going to be in your blood, and that's why we call them B, because they actually come from bone marrow, hence the term B, and they are going to be involved in the antibody response primarily, and that's known as the humoral response. But again, we are most concerned with the absolute lymphocyte count. How many total lymphocytes do I have circulating around? And that value is between 1 to 4.8 thousand cells per microliter. So just to work through this, or rather just to talk about this, right? So when we calculate this NLR, neutrophil to lymphocyte ratio, what we do is we find out what the absolute neutrophil count is, right? So we get the absolute neutrophil count, and we put that on top in the numerator, and then we divide that by the absolute lymphocyte count here, whatever that happens to be on our patient. And then we have found something rather interesting. If that ratio is between 3 to 6, these patients tend to do very well. They tend not to have as many problems. If the value is between 6 to 10, this is concerning. These are patients that tend to do a little worse, tend to have a more problematic or tumultuous course. And then if their value is between 10 to 20 or greater than 10, these patients tend to be fairly critical. They tend to require ICU care to include a ventilatory support. As of this video, this is 29 March 2020, there are no known survivors that had this ratio, that had a neutrophil to lymphocyte ratio above 20. Now, as of this video, and you can reference this on the TWIV video that I referenced earlier, there is a patient that had a value greater than 20, and it appears that he may actually be surviving his course. He's still in the ICU, still on a ventilator as far as I know, but it is possible that this particular patient, with good aggressive care and some novel or experimental therapies, may actually survive his course. But in either event, values above 10 suggest rather critical patients. And these patients tend to have much higher rates of morbidity and mortality. And then just as a final sobering note, unfortunately, if somebody does have to go on a ventilator, they require ventilatory support. They go on to develop an ARDS-like picture and require aggressive ventilatory support. Currently, with the data that we're gathering, that we've gathered, you're looking at approximately a 50% mortality rate. Right, so it is very concerning if you have somebody on a ventilator. and if they have to be put on a ventilator to support them, these are patients that tend to not do very well. 50% of them end up dying at this point. So that's unfortunately, a very, very sobering thing to remember. Okay, I'm going to go ahead and cut the video off here. Hopefully you all found this helpful, and hopefully you can take some of this information and integrate it into your clinical practice, particularly this idea of the neutrophil to lymphocyte ratio. I think is something that, if you're a paramedic and transporting somebody out of a hospital, or you're a respiratory therapist, and you're reviewing somebody's chart, right, because you're going to provide some care for them, and you're taking care of these COVID-19 patients, this is probably something that you want to pay attention to. In addition to all the other things, this is another tool that you want to put in your toolbox. And every day, as you're looking at their labs, you should probably be calculating this, because if this is getting higher, that suggests a patient who's deteriorating. If it's getting lower, it suggests a patient may be improving, right? So I think it's an important concept to consider. And again, I want to be very clear that none of the videos that I'm doing should replace your institution's policy, procedure, and clinical practice guidelines. That is not anything that I'm telling you to usurp. I'm just giving you additional information, and hopefully you can take that information, perhaps integrate it into your clinical practice, show it to other people, and maybe that can help facilitate changing clinical practice guidelines if indeed they need to be changed. And again, this information is only as recent as I can make it, and this, as we understand, is a highly dynamic and evolving situation. But be that as it may, I do hope that you still find this information helpful up to this point. All right, everyone, you all take care.